get the session started?
Okay.
Okay. Hello, everyone. Thank you for joining DataCon LA 2020. Welcome to the Data for Good track, and soon we'll be listening to the Healthcare Deserts. How accessible is U.S. healthcare? Session with Andrew Kaszpurenko. I'm Annie Flippo, your host, and our co-host today is Ritesh Rathia, and we'll be moderating the chat and Q&A for the duration of the session. Andrew is the manager of Advanced Analytics at Edwards Life Sciences. He leads a team that uses a variety of machine learning and AI methods to build models that inform leadership and business partners to help patients get treatment for aortic stenosis. Prior to joining Edwards, Andrew has over a decade of experience working in a variety of industries from life insurance, health insurance, finance, and direct primary care. And without further ado, I'll hand this over to the speaker. Thanks for being here. Here's Andrew.
Hi, good afternoon, everybody. All right, so let me share my screen and start with the presentation. All right, so I'm going to take you guys can all see my slides. So as Annie introduced, name's Andrew Kaszpurenko with Edwards Life Sciences. I've been the THV division for about 3 years now. We do a lot of machine learning and AI methods to kind of build a bunch of different models and kind of inform leadership and kind of examine a bunch of different things that are going on in the healthcare space. A very high level overview of Edwards Life Science. It's a medical device company that's focused mainly on structural heart disease and surgical monitoring. We're based here in Irvine, California, and I'm within the THV division. THV division does the transcatheter heart valve repair. And basically what this is a minimally invasive procedure where a heart valve is basically inserted into the heart through the femoral artery and back up and over the aortic arch and into the aorta. This has been around since 2011, and it's treating mainly a small subset of population that has what's known as severe aortic stenosis, where basically calcium builds up on the aortic valve. Going into this, the problem kind of occurred is basically aortic stenosis occurs in patients that are mainly older, about 70 to 80 years old. Not everyone gets it. They have a hard time figuring out what's the underlying cause and factors that go into it. But that's kind of irrelevant for this. With this, what happened was Medicare back in 19 was looking at revising which hospitals can do basically this TAVR procedure. And so there are some organizations that are pushing for tighter requirements and some organizations wanted looser requirements. And for us, it was a matter of looking into like what all these different kind of requirements would mean for patients getting access. And so kind of the problem statement that got presented to me was, how do I show based upon different assumptions with the different organizations, what Medicare has currently on the books, like what would a policy change, how much would that have an impact on access for patients? And a lot of this kind of actually goes into how far is a patient willing to travel to get treatment? And there's different papers and research out there on how far a patient's willing to actually get treatment. Now, one thing that makes this a little bit unique is these are, 70-year-old patients, 80-year-old patients, and I don't want my grandparents on the road driving. So this is also caregivers are having to drive these patients, to the hospital appointments and the visits. And so what I needed to do is kind of create something that would be visually easy to digest, but also that we can kind of quickly query and look and see how a policy change of, would have, what would that mean on access overall? And so what we wanted to create was this map of the US, and we're in color code where kind of these deserts would exist. We need it to be as granular as possible. We need to be able to kind of adjust things real time. We need to kind of overlay some, population, some poverty information. We wanted to be able to include different types of scenarios in there, but we wanted to have a really deep look into all the different things that could possibly happen and occur with different scenarios. So that was kind of the business problem I had presented to me. And so it's kind of thinking about, okay, which tools do I want to use to play with this? And so Tableau is my kind of go-to favorite tool for data visualization. Python just absolutely love for cleaning up and organizing data. What I kind of ran into is, here comes the technical problem though, of there's 30,000 zip codes in the US, and we don't want to have Tableau do the calculation to the nearest point every single zip code, you know, because that'd be taking 30,000 zip codes going against 30,000 zip codes, you know, which gets us to about 900 million. You only need to go one way. So you can kind of cut that in half. It gets us to about 450 million, but we don't need Tableau doing 450 million calculations. It's pretty heavy burden. So let's see if we can kind of like simplify this. And so kind of taking a look at what like the input tables going into this would be, is on the input side, it's basically there's two kind of tables. Both are publicly available. One, if people are looking for good data sets to play with, Medicare has a lot of great information out there that could be played with, that has, you can look up by different procedures and coding and kind of get a feel for which hospitals are doing what volume. And that was going to be the issue with the requirement, was the hospital had to have an experience with so many of a certain type of procedure or another type of procedure and or this type of procedure. And there's a bunch of different kind of policies going through, being pushed by different organizations for the amount of these different procedures that they had to have done. So we wanted that we can then kind of create a bunch of different little scenarios. So if the scenarios that this hospital does meets the minimum requirements, that they'd be, you know, within the potential. If they're not, then they'd be without it. So using that Medicare data and then matching it up against a lat longitude data set that has just all the US zips with their lat long, we can then kind of create that map look at the US, going back to this desired end goal of having a US. I want to be able to color code every single zip code in the US because it visually just, it grabs the eye. So doing that, the first thought was, okay, let's just create a table outside of Tableau. We're going to color code each zip code where the closest hospital is. And then we can mask only the hospitals we're interested in. We'll take the minimum distance from that. It gets us to about 450 million calcs. To revise it, actually, we only need to do the 800 hospitals that we have kind of in that target list. So then we kind of get down to 24 million hospitals. And so essentially what I'm going to be doing is taking each zip and go point by point by point to every single hospital and go, okay, what's your closest hospital by distance? And then kind of set that to the side. And then literally shift over to the next zip code, do the same thing to another 800 different hospital zip codes and get that distance and, you know, the minimum distance to the nearest hospital. So at the end of the day, it's very brute force. And like I said, this is kind of the first part to it, which is the brute force method. And then there's kind of another revision, which I'll show, which is way, way faster. But at the end of the day, what we're going to do is just import the data. We're going to clean up, just general kind of cleanup whenever you kind of do CTL stuff. And then we're going to just kind of do the calculation of the distance for every single zip code to a hospital target. So net, very clean, simple, just import it, drop the duplicates, kind of keep it as nice and clean as possible. You know, some hospitals are in more than, some hospitals, or there's, sorry, let me rephrase that. There's more than one hospital in the same zip sometimes. So we can easily take those out to just kind of make this data set smaller and smaller and smaller and try to minimize just the amount of calculations that we're going to have to do. And then with the hospital file, which is this file over here on the right, or upper left, I mean, they didn't include lat long, so it had to basically kind of mash those in there. So mashing in the lat long, and then now create the calc distance. So it's going to then, we're going to take the data frame, we're going to paste out every single hospital, and then we're going to paste out all 30,000 zip codes to every single one of those points. So we're going to now wind up with about 18 million rows. Functionally, this takes quite a bit of time to process through, just basically using a simple apply function. Geodesic, GeoPy has a function called geodesic, which allows you to do that calculation fairly easily. But again, on an i7, it's taking roughly about an hour and 25 minutes to complete, which is far from ideal. But at the end of the day, we have a data frame, all the zip codes, and we can easily now just get the min distance from that. And so what that then kind of leads up to is just setting up the visual, which is as simple as just kind of dropping it in Tableau, color coding it as simple, so everyone could see whether it's good or bad. You know, so I just did red and green for close, and it can start to overlay some information onto it. And so then we start now layering in on different population metrics, different income metrics, and you can kind of start playing with different other features. You can play with overlaying obesity rates onto this, even though our disease doesn't have anything to do with obesity, but you could layer on other factors that start becoming more interesting. And it allows us to quickly kind of look and go, okay, how many people are over 65 in the US, which is this what our this valve that they're reviewing is treating mainly over 65-year-olds. So how many of the population, if they're only willing to drive 50 miles, wouldn't have access? And how many of those are low income? And then we can kind of start to play with some other metrics. So it leads kind of to the next thing of, this is incredibly, an hour and 25 minutes is too long. So how do we kind of speed this up? And that's where the kind of the very fascinating thing comes in, is first kind of assessing the why this is taking so long. Is that there's a lot of repetitive calculations. Like it's, you know, we already, once we've done the calculation that, you know, Huntington Beach is closer to Irvine than it is to New York, I don't need to calculate if, you know, Irvine's closer to Los Angeles versus New York. Like we've already kind of dissolved that. So let's try to break the US down into regions or zones or something like that. And so originally I was kind of thinking about just taking the US and splitting it up into different regions and zones, but then we have some border issues of, you know, along as different zip codes are along different borders, it's going to start to cause some issues. So then kind of thought about, okay, how do we just search that region? And so what it kind of came down to is we're going to take the surface space, and basically, because when you think about it, lat long is just 2 points on a surface. So we can then kind of cluster things together. And there's a library in Scikit called KD trees. And basically it's a nearest neighbor calculation. Nearest neighbor calculations with KD trees, the best way to kind of think of it is it's taking this problem and it's going to divide it into smaller, simpler spaces. And when you're querying it, it's going to search through that tree to find that short distance as fast as possible. So it's going to take it, split amongst the medians. So we kind of got two groups. They could be roughly equal size. So we've just taken our problem space and cut it in half. We could then kind of just go, okay, so there's this new point Z that we all of a sudden have. Where does it fall on this kind of thing? Well, it's greater than, 6. So it can kind of start to fall down this other path. We can subdivide this other, sections, this tan section off, and start subdividing each section and solving kind of for that problem that we're after, which is just this one area. So all of a sudden when a new point comes in, this point Z, we can just quickly traverse, it's just like a giant if statement. It traverses it through this kind of KD tree methodology. KD trees will not work in a hyperdimensional space. Basically, because we're on a sphere, it won't work, but ball tree basically does the same exact thing. Ball tree, the tree being like the KD tree, the ball being basically instead spheres are drawn, and then the Haverson equation to be applied to it to figure out which is the closest based upon the location of these circles within a circle within a circle. So again, it's about taking the problem. What we have is all these different zip codes, and we want to reduce it down into a smaller subset. And that smaller subset, the way to kind of do it is just break it into different buckets. And then once we have those buckets, it's only having to do a small amount of calculations on a small area, which again, taking the same code as we had before, and this time just adding a thing for different scenarios. And what we get is, well, one of the first steps we have to do is convert the lat long into radians. And then we create these scenarios into a data frame. And then we just run it through. And basically, it's very as simple as this. It's one line. It's basically taking the ball trees, it kind of takes it, puts it into memory as this ball tree, which creates those kind of subdivisions. And then we just query against the ball tree. And it's going to return to us a radian measure. You take the radian measure and just convert it back up into mileage. So just multiply it up. And you got your distances. The k=1 is going to give you your closest one. If you put in 3, it's going to give you the 3 closest hospitals. But net in the end, what we have is a very short, very small distance, a set of results. It takes the results, just take it into a data frame, and just import it, kind of do a bunch of the rest of the cleanup. And then you just run each of these different scenarios and then stack them on top of each other. At the end of this, it took roughly about 4.5 seconds to run. So we went from about an hour and 25 minutes to about 4.5 seconds to run 2 scenarios at once, whereas the other one was just running one singular scenario. So it's a massive improvement to the point that the code can now be embedded inside Tableau if we wanted, which then kind of leads to the next thing of just the visual of it. And so what that led to was thinking about how do we want to kind of display the information and share out like what we're seeing. And so we can kind of think about the problems in different ways. We can take a look at it and kind of go, okay, well, this is what we currently have. This is under what's a potential scenario. And at the time when we're examining this, we were looking into 4 or 5 different other possible scenarios. And it's going to do the thing when I'm presenting. It's not going to work. Oh. Okay, there we go. So we could take a look, and this was like a current kind of set of the rules and looking at what the potential set of the rules would mean. We can also take a look at if a patient's only willing to travel 25 miles, there'd be 10 million without access. If a patient was willing to travel 50 miles, how much would that mean? It'd mean there'd be 3.6 million without access. So again, a lot of this could take, we can then start to slice and dice along income levels. We can look at other metrics such as certain really big dominant hospitals in the area or smaller hospitals. We kind of run the analysis with a bunch of different scenarios very quickly. Because now we're down to about 4 seconds to run this thing. It runs fairly quick, so we can start to play with things very iteratively and very quickly to kind of see which types of problems or different scenarios look interesting or might provide a viable solution to kind of push with Medicare. Which this all then kind of leads into the final of just kind of the visual. On the visual, it was kind of just like to make this comment on visual best practices is just white space, white space, white space. If things don't matter, take them out. There's the default settings for Tableau are great for a lot of things, but one of the things I always like to do is just take out the grid lines, take out the shading colors, set a very standard font and palette size or palette color setup, and everything should just be kind of nice and clean. And at the end of the day, you get kind of a nice, clean, simple dashboard. As I like to say, it's easy enough. I could take it, hand it off to my dad, and he's going to know how to use it. It's very clean, very simple, very easy. And so all this kind of just led to our own internal analysis. It gave us a lot of different understanding of what's being proposed. It allowed us to kind of push back with Medicare on certain aspects. The big thing was just kind of quantify, if this policy went into effect, how many patients would be without access? How many minorities would be without access? How many low-income areas would be affected? But there's other applications with this too. Everyone I've talked to that works in supply chain or logistics, this kind of problem of figuring out close distances is a very big issue. If there was a pandemic going on and you need to distribute out vaccines, where can we distribute that would give us, so which hospitals will give us a good set of patient access coverage? You can see this with food accessibility with these deserts, and a lot of it's again about closeness to another distribution center or a fresh market. There's many of these problems are around just kind of simplifying the problem into easy digestible parts that then also visually is easy to understand, it's very clear, and you kind of know that the end user can take, that an executive could take and look at and understand what's going on, where the shortfalls are and what needs to be done. And that's basically what I have. Edwards Life Sciences, we're always looking for more data people. It's a wonderful organization to work for. And so just thought I'd throw, a shout out to Edwards on there too. And that's about it.
Great. Thank you, Andrew. Let's take a look at the Q&A chat section to see if there's any questions. Does anybody have any questions? Feel free to add it here. So I have a question, Andrew.
Yes.
So you did all this analysis about how accessible U.S. healthcare is. What is the takeaway from Edwards Life Sciences as an organization?
For us at the time, what this was being used for was a national coverage decision, which meant these patients, whether they get access or not, and basically to this treatment. Not all of us can be kind of lucky to live near, Cedars-Sinai. There's farmers out there, middle of the country, but it's not even just in the middle of the country too that, want access to a procedure. And if, the restrictions are put in that are incredibly restrictive, that only certain hospitals can do this procedure, the farmer's not going to have that option to travel to Cedars-Sinai. But if there is a hospital that's down the road that can do it, they can then go get that treatment there. And so what's happened is, net at the end of the day, Medicare did issue a change in policy. They did loosen some restrictions on some things and make it tighter on the other, but net in the end, it allowed more centers to open up. So, and this map is not precise, but we basically kind of went from a scenario of kind of it looking like this, where there's a bunch of these little red zones where patients couldn't get access up, especially up here in the Dakotas. And all of a sudden now we're kind of, if a patient's willing to travel 50 miles, we cut it basically in half. We went from 5.8 down to about 3.6 million would be without access to this procedure. And a lot of it's just kind of filling in those smaller areas, just because, you know, that farmer can't travel, you know, all the distance. They can't be traveling, you know, hundreds of miles to go get, you know, this desired treatment. And also, very importantly too, is the caregivers. The caregivers have to take quite a bit of time out to go, you know, drive that patient to, you know, the hospital and take the parent back and forth. And some of these, you know, times they're visiting the hospital 6 or 7 times before they finally have that procedure, just to get all the testing done ahead of time. So it could be a high burden on, you know, the caregivers and the patient. So net in the whole, the way the current proposal is, it looks pretty good for coverage and access for patients.
Great. This is so I work in advertising. We also use a lot of location data. So now you gave me some good ideas how to process it better, faster. If people want to connect up with you, how can they, you know, are you on Twitter? Like, you know, how would they be able to follow your work?
Yeah, the best is actually through the Wovi app. Just message me through there. Yeah, I actually kind of maintain a pretty low social profile footprint, but I'm definitely on there, and I believe I'll have my Edward's email on there also.
Okay, we have a question that just came through. I'll read it to you. You said you had a lot of experience in healthcare. Is there a lot of experience required to get insights from Medicare data? And where can we find Medicare data? That's my question.
Yeah, so some of the healthcare data can be very complex. Some of it can be somewhat easy to layperson understand. The Medicare data, let me go back. So they actually have a wonderful interface that has, so if you just even Google, you know, the Medicare data, I'll let this pull up a second.
I assume this is all somewhat anonymized.
Yes, it's all anonymized. It's all publicly available. And what you can see is when you kind of go into, I mean, if you just type in, you know, Medicare hospital, you know, claims data, they have basically it kind of put out there with all the different procedures, all the different IDs, and where all the locations are. And they have readmission rates, they have, you know, mortality indexing, they have quite a bit. But then the other thing too is you can kind of filter by different categories of that the procedure, that they do certain sets of procedure codes, which was the thing for us that we were looking into, was we were looking for certain types of procedures, because that was going to be part of the minimum requirements, that the hospital had to have so many stents done, or they might have had to have so many open heart surgeries done to be qualified to be able to do this. And so this allowed us to kind of filter and kind of set some different guidelines, but then we can also kind of look through the data individually and go, okay, this hospital is right on the borderline. I think next year they're going to be there. And this hospital, I don't think they're going to make it. And we can kind of start playing with different little scenarios of, one, of, you know, what's the reality at the moment, and two, of just like, okay, what do we think is the actual real possibility? And so, but to the question, you know, if you just Google Medicare data sets, they have actually quite a bit, and it's very well documented too. That's the one other thing I would say is has some of the best documentation out there for what each column means and what the how each of the metrics are derived. But I mean, even just a simple like hospital comparison, this general information. There's 5,300 hospitals they have in here, and they have a myriad of different variables and weights that can be used to kind of take a look at things.
Cool. Okay, another question just came through. Did Medicare ask for this analysis, or did Edwards do it on its own?
That actually, I don't know. I just know what was kind of given to me. So when my boss came to me and said, "Hey, let's take a look at these things," I don't know if they were actually asked by Medicare. I do know that some stuff was presented by Edwards to Medicare, but I actually don't know if this was directly asked by them.
Okay. Another question in the chat is, can you provide some sample Python code that all the interesting stuff you mentioned in your slide?
Yes, and I'll put that up with the deck also. But it is fairly simplistic at the end of the day. I mean, this is at the end of it, it is 130 lines long and tons of comments of just kind of junk. It's really, I mean, the reality is it's probably maybe 30, 40 lines, but yeah, I'll include this in there. It's a fairly simplistic kind of code. We kind of tried originally that brute force method, which works. But the nearest neighbors, just it drops the processing time down to a fraction.
Great. Yeah, so this video is being recorded, will be posted after all the videos are processed, and slides and extra code that presenter give us will be provided to all the attendees to this conference. So thank you. Let me see if there's any more questions. Cool. Well, thank you, Andrew. That was really enlightening. That was very interesting. Yeah, it's amazing that there is a lot of red on the map, and probably we can do better.
Yeah, it really is. It's kind of amazing. Just there's a lot of these kind of little blind spots where I think we're definitely kind of spoiled being in Southern California with a lot of access to a lot of amazing hospitals, but not everyone kind of has that, opportunity or availability.
Yeah, I agree with you. Well, thank you, Andrew. That concludes the session, and everybody have a great rest of your day.
Thank you.
Thanks. Bye.